Welcome to Communities Changing Minds, How Crises Spur Action. My name is Brett Schultes. I'm the Transforming Health Reporter at WITF, a public radio station out of Harrisburg, Pennsylvania. I cover health policy and community health issues that affect Pennsylvanians. The guests today in our scenario-based discussion in order of appearance are Fred Herron, Director of Public Safety, Bensalem Township Police Department in Bucks County, Sabah Mohammed, Policy Counsel at Treatment Advocacy Center, Matt Weintraub, District Attorney in Bucks County, Benjamin Barsky, Legal Research Fellow at Scattergood Program for Applied Ethics of Behavioral Health Care, Oscar Kazin, Judge, Bexar County, Texas Probate Court, Eric Smith, Bexar County, Texas AOT graduate, and Elizabeth Sinclair Hank, Director of Research at Treatment Advocacy Center. The year is 2019. Derek is a man in his late 20s. He's staying at an extended stay hotel in Bensalem, Pennsylvania. Now, Bensalem is located in Bucks County, just north of Philadelphia. The county has a population of about 630,000 people. Derek has untreated schizophrenia, but has been managing to meet his basic needs, and he's keeping it to himself for the most part. One day, he turns on the TV and only gets static. He's convinced that the CIA is trying to get a message to him, but he can't interpret it. He goes to the lobby to tell the hotel clerk what's happening and to ask him if he can get help to interpret the message. The hotel clerk tells him no, and Derek starts to argue with him loudly. The hotel clerk is worried the situation will get out of hand, so he calls the police and asks them to send a crisis intervention team trained officer. Fred, you are a highly trained police officer. What do you do when you arrive on scene?
First, we want to try to talk with Derek as best as we can. Obviously, if he's suffering from a mental breakdown at this particular time, it's going to be a lot more difficult. We're going to try to want to establish where he's from. Does he have any relatives? Is there anybody that's staying with him at the hotel? Where is his actual address? Where is his his abode, and try to research a little bit more to see if we can get someone out there to help him before we go down any other paths. Certainly, if it results into a situation where he is causing a major disturbance or he's a danger to himself and others, then we'll have to take other actions. But our first sense would really to be just to kind of get him calmed down and possibly get him with some sort of family member or someone that could at least care for him before we had to take it any further.
Yeah, it sounds like you're really balancing a couple of different things there. Is that right? A couple of different priorities that you have.
One of the things with police work in general is that no two calls, no 2 days, no 2 minutes are exactly the same. So every person that you encounter, every individual that you encounter, whether they're a victim of a crime, whether they're suffering from a drug addiction, or they're suffering from some mental health issue, has to be handled differently. But you want to find that balance with that person. You want to find where is that common ground, where is that middle ground, because what you don't want to do is you certainly don't want this situation escalated to a situation where you might have to take him into custody, because that might not be the proper avenue for Derek. Trying to get him somewhere safe would be the best case scenario, but you also want to make sure that he is safe and the people you are getting him to are safe, because it is unpredictable. You don't know what's going to happen to him in a minute or two. If he thinks it's the CIA through a television now, what could it be in 10 minutes? So it is a very, very fine balance. And, as we know, police don't receive a ton of training in this area. There's so many avenues of law enforcement and other social issues that we're involved with. CIT training, you get 40 hours, you can get 80 hours, depending on some of the other training. Officers might advance to more than that, but we're not sending them out much more than that type of training. So it really is we're trying to, put a Band-Aid sometimes on a bleeding artery. And that only holds for so long. And if it's really that bad of a situation, that Band-Aid won't hold at all. So we're going to want to try to find, at least in this case, at this time, the situation hasn't escalated. We're going to want to try to reach out to a relative or someone that could take care of Derek, so we can get him through and maybe get him into some help, some treatment before we get him involved with the criminal justice system.
this scenario, the understanding is that you recognize Derek because you've been called to similar instances in the past,
Right.
and you've come to know his sister Sabah, who in this scenario is his advocate. So, Sabah, you're Derek's sister. You receive a call from your friend Fred. He tells you about the incident with your brother and asks whether you want him to take Derek to the hospital or arrest him for disturbing the peace and take him to jail. What do you tell him?
Well, I'm very lucky that someone in the community knows him and can call me. Before anyone became familiar with him, it was sirens and guns and screams for him to comply with communication that he doesn't understand. So just the fact that I know that Fred is out there is calming, but it's still difficult. The decision between help and jail is no decision at all. It's hell. When he was first diagnosed, naively, I thought schizophrenia, of course he's going to the hospital and I'll get my brother back, but that never happens. He goes into the hospital and he comes right out because they're only dealing with the loudest crisis. And because his psychosis isn't loud and he doesn't have a knife in his hand, he gets right back on the street and finds his way right back to me, still trying to interpret messages, and he doesn't get help. If he sits quietly in the hospital, even while his psychosis is going on, he'll come right back out and be in the exact same place. And we've been cycling through this for years. As much as it shames me to say it, jail is where he'll be safe. I know he won't start fights, and I know he get 3 meals a day. He'll be where I can see him. It's through plate glass, and he has that orange jumpsuit like a criminal, but that's the best of the worst choices that I have right now.
So in this scenario, Sabah calls me. She's been following my work as a reporter for many years and knows I take an interest in mental health issues. She tells me what happened and that she's angry that the police had no choice but to take her ill brother to jail. I decided to write an article I call the Treatment Advocacy Center to see if they have any research into this issue. And there, Elizabeth, the Director of Research at Treatment Advocacy Center, what did you tell me in this scenario?
Yes, well, first I want to thank you, Brett, for covering this important issue. I believe that the more we get this, the failures of the mental health system into the public awareness, the more we are able to produce change. So unfortunately, the situation is all too common and happens throughout the country. I conducted a research study in 2019 where I surveyed law enforcement departments throughout the country to try to understand and quantify their role in psychiatric crisis response, specifically looking at that encounter when an individual is in mental health crisis and the transportation of that individual to wherever the officer decides to bring that person. We found that the distance to transport someone to a mental health facility is 5 times farther than if that officer was to transport someone to jail. So purely just the time and distance that the officers and law enforcement have to make every day, it incentivizes the criminalization of mental illness.
Talk a little bit more about that, if you could, Elizabeth. When you say it incentivizes the criminalization of mental illness, it sounds like you're just saying that it's easier to not, take that person to a inpatient mental health facility. I have a feeling, though, it's not just about the ease of it. Are there other factors as well that we haven't mentioned yet?
Since the peak of psychiatric inpatient hospital beds starting in the 1950s, we have lost 97% of our psychiatric hospital treatment beds. In that same amount of time, the number of people with serious mental illness who are incarcerated has climbed exponentially. It's the failures of the mental health crisis treatment system has resulted in an enormous number of people with serious mental illness entering into the criminal justice system.
Well, let's talk more about that. District Attorney Weintraub, your office is responsible for developing the case against Derek. You're familiar with him because he's been arrested for minor offenses in the past. You're frustrated that this case and others like it are taking up valuable resources. And those are resources your office needs to hold serious criminals accountable for their crimes. So what do you do in this case, District Attorney?
It's a great question, Brett. First of all, I want to stress that not only am I concerned about the utilization of limited resources, but I care about Derek. I think that once somebody that suffers from mental illness is prone to commit low-level criminal offenses or even moderate criminal offenses, they get caught in a spin cycle, caught between a rock and a hard place. And as Elizabeth said, or as Sabah said, there is no good place. The least evil sometimes is that they get sent to jail, but that is far, far from a perfect fit. It's no fit at all, frankly. So one of the things that we have, at least now, we have some specialists that are very adept at handling and working through the mental health system as prosecutors. But we need a better and a bigger system even than that. And so a couple of years ago, I entreated the Quattrone Center for Fair Administration of Justice at the Penn Law School to do some research for us and author a report. Benjamin Barsky, who's on this call, he was the primary author of that report. And the report, frankly, contained no surprises, but it really made it summarized it and made it very digestible for not only me, but for all of the stakeholders in the county to consider the efficacy and the value of having a mental health court here in Bucks County, so that when somebody like Derek does get enmeshed in the criminal justice system, we will, I should say, because it's not completed yet, we will have a mechanism for which to treat Derek, to address his specific needs, not just Derek, but every person like Derek who has that type of dual issues, whether that's mental health or drug and alcohol, and some type of criminal conduct for which they have to be held accountable. So the stakeholders here in Bucks County have bought into that. It is an onerous process because we're starting from scratch. We have a bunch of disparate pieces that we've cobbled together, sort of a helpful system for these people, but we need to do a better job, and the stakeholders here are well on their way. I've been told, my fingers are crossed, I've been told that we will have a mental health court here in Bucks County by the end of this year, and I'm very encouraged by that. It's very much needed here.
Well, that's really encouraging to hear. I wonder if you can just take another minute to just talk a little bit more about how mental health court would differ from what you already have established, for the person who's not really familiar with that nuance.
Absolutely, Brett. The difference as I envision it is that a person who has pretty obvious mental illness issues or has been diagnosed in the past or even is readily apparent, they will immediately be diverted to this mental health court. They won't have to wait for their formal arraignment date. They won't have to wait for their preliminary hearing. They won't have to wait for a trial date. We will attempt to get them assessed more immediately, get them the resources, whether it be medication or treatment that they need much, much earlier in the process. And if there's a way to divert them, whether it be via pretrial supervision or bail, into the treatment protocol that they need so that they're not just languishing in prison, that's the objective. And then certainly the end goal is to make sure that whatever resolution that case required not only keeps the public safe and gives the public redress, which they're entitled to certainly, but will address the issues, specific mental health issues of a person like Derek, because the goal, frankly, is to make Derek as healthy as he can possibly be so that we never have to interact with him again in the criminal justice system. That's a win for everybody.
Thanks for that detail. Let's actually take it over to Ben. In this scenario, Ben, you receive a call from the district attorney asking for a report. So what do you do from there?
Thanks, Brett. Well, the report has to locate Derek's story within broader trends that have already been spoken about, where criminalization of people with mental disorders have been staggering and to many degrees disturbing. And we have to evaluate how a mental health court can and cannot help. And to do so, we really have to rely on the evidence and the broad base of research that has been produced in this area. And really, there's three characteristics, if you will, that have been spotlighted through this research, kind of the good, the bad, and the ugly, if you will. I'll start with the good. It's been alluded to already, but we know that jails, prisons, other detention facilities for people with mental disorders are very corrosive environments. And so the value of the mental health court is, of course, the diversionary process. And the report has to touch on the logistics of that process, bringing together multiple parties. We're talking the judges, members of the prosecution team, public defenders, members of government services, and bring those individuals together to create this diversionary process. And in addition to these logistics, there's really two elements or ingredients that this report has to touch on. The first one being the mental health care element of the court, which is we need to have a network of providers, both mental health and substance abuse providers in case of co-occurring disorders. And what's extremely important and to keep in mind, and this is what the research kind of bears out, is the importance of informed consent and for participants to be buying into a tailored plan. So in this way, it's a two-way street where the more an individual can participate in their plan and feel empowered and self-determined through that treatment plan, the higher the success rate. And that goes hand in hand with the second element, which is really the community supports. And what do I mean by the community supports? Housing resources, health insurance in case the participant needs it, transportation services, identification services, right? Every single one of these resources, a lack of them is a determinant for worsened conditions. So it's very important to keep those elements in mind. And then the report has to touch on what a mental health court cannot do. The research so far is very clear that mental health disorders, the same way as COVID-19 in many ways, are tied to structural factors. And what do I mean by that? Segregation, poverty, structural racism, all of these problems are not necessarily those that the mental health court are going to solve. In fact, the mental health courts are not going to solve these issues. So the mental health court is one intervention along a broad spectrum of interventions that are necessary to unravel the criminalization of people with mental health conditions that have occurred as has been said already in the past decades. And tying into this, an issue to keep in mind, and DA Weintraub alluded to this, and I think this is a point to emphasize, mental health courts that are least restrictive, and what I mean by that is the stricter that a court is, the more or the less we're affording the opportunity for participants to enjoy the benefits of the court, to divert back into the community, and to enjoy economic self-sufficiency, self-determination, and for them to be pulled out of the system entirely. So this process of the two-way street, the engagement on both sides of the process is very, very necessary. And the more that we can eschew reliance on unnecessary coercive devices, the more the research shows that mental health courts will have success. So those are the ingredients of the mental health court that the report will bear upon.
Now let's check back in with Derek. While in jail, Derek is found incompetent to stand trial. He's placed in the state hospital for 4 weeks, is restored to competency, and returns to jail to face charges. Given the combined amount of time he spent in jail and at the hospital, the DA agrees to dismiss the charges. Sabah picks him up from jail and brings him to a homeless shelter because her husband has made it clear that Derek cannot live with them unless he gets treatment for his illness. After living in the homeless shelter for 30 days, a place is found for him in a group home. For the first few months, things go well for Derek. He decides to stop taking his medication though, because according to him, he never really needed it in the first place. One day, Derek leaves the group home and wanders into traffic where he's knocked to the ground by a car. A medic provides first aid. When it becomes clear to him that Derek is delusional, the medic transports him to the emergency department. There, Derek is involuntarily committed to the hospital. He remains in the psychiatric unit for 5 days and is discharged. After returning to the group home, Sabah is informed that he will not be able to remain there if he does not take his medication. Remembering what she learned in her NAMI family-to-family class about assisted outpatient treatment, Sabah makes inquiries to find out if there's an AOT program in Bucks County. So Sabah, your brother's refusing to take his medications and is at risk of losing his spot at the group home. What's going through your head right now?
Terrified. Housing is one of the most difficult parts to secure. I have spent at least 48 hours each time this cycle happens trying to find housing. There are homes that won't take him if he has a record. Homes and disturbing the peace would disqualify him from those homes. There are homes that you have to have insight to your illness. And of course, this is one because they want that medication compliance. Some homes don't know anything about SMI and they're just as bad. He'll run away. I found him on my porch or park benches, and AOT seems like the right thing. They want medication compliance. We all want Derek to take his medication. So they'll help him come to that decision under the watchful eye of a judge and a team, and everybody wins. Derek has a shot to thrive. He gets a chance to have his dignity back. My family did not make the decision lightly to not allow him to live with us. The last time he did, he woke us up throughout the night complaining of telepathic messages. We could not work the next day. We're always taking time off to either find him, attend to his housing, or just put our wellness first. And with AOT, he stays in the community, he stays in his housing, and we have a better chance of getting my brother back, somebody who wants to contribute to the world and thrive with his family. Really important for Bucks County to take seriously implementing AOT into our communities. I think AOT, assisted outpatient treatment, would be great for Derek because it's another tool in the toolbox. I make calls for housing, medication, doctors, anyone who will work with him. And if he can get a court-ordered team that's in the community to help him adhere to medication, then that's one more step in the right direction. It involves a judge, but it's not criminal. And I know that can seem like an oxymoron, especially for families of color, but they don't just decide for you when you're in AOT. Your team works with you to implement a plan to get you to long-term well-being. And that's what Derek needs to get him on the right track. That's what he needs. He needs treatment before tragedy. AOT provides that. It gets your loved one, and hopefully Derek, into a safe space where police intervention will never be on the table because he is someone with a mental illness, not a criminal. And AOT provides that gateway and gets him out of the cycle.
In our scenario, Sabah calls NAMI Bucks County and is informed that there is no AOT program available in Bucks County. They explain to her that despite the law allowing for such a program, the community has decided to opt out of implementing it. Armed with this information, Sabah approaches the district attorney to ask him if he would help her advocate for an AOT program in Bucks County. And just to be absolutely clear, District Attorney Matt Weintraub has said he supports AOT, but in this scenario, he says there are some concerns about resources and some other complications. And so before he commits to her, he wants to first learn more about how other communities have overcome similar barriers. He reaches out to Bexar County, Texas, because he's heard that they have had a successful program for many years. Now, Judge Kazin, you've just received a call from District Attorney Weintraub. He tells you he's interested in learning more about AOT. He explains the concerns that others in his community have about it, and he's heard about your program and wants to know how you overcame those barriers. So what do you tell him, Judge?
I mean, the first thing I would do is, if I could, and from a long distance, give the district attorney a hug. We need more like that. In order to overcome that type of barrier, we all have to ask ourselves this question: is Derek an acceptable loss? Is it okay for us to say that Eric gets to live on a revolving door where his family and sister get to watch him deteriorate and get into the depths of the worst life you can imagine? Is that an acceptable loss? And I think once you get past that question, you start looking at what works and doesn't work. I mean, we know what works. Community mental health policing works. We know that diversion from criminal justice works. We know that increased funding for voluntary mental health services works, so that people can get help when they need it before they go into crisis. But Derek is not in that group. Derek is in the group that eats up the vast majority of our resources, who does not recognize, because of his serious illness, that he has an illness that needs to be treated. And we need to figure out a way in the community to make wellness his habit rather than illness. And if you speak to any one of his family members, they'll be the first one to scream out loud, I can take him to as many clinics as you'd like. He's not going to cooperate. You've got to come up with a different mechanism. And assisted outpatient treatment with the help of a court, I think, is one of those mechanisms.
You know, Judge Kazin, here in Pennsylvania, a law was passed about 2 years ago that makes AOT something that counties can enact. Interestingly, no county has enacted that thus far. One thing that I hear sometimes from county mental health program coordinators is, and from others, is that they're concerned about what's essentially what they would call an unfunded mandate, or being told to provide some kind of resource without getting additional funding for it. And that's really on the backdrop of Pennsylvania having what many call relatively flat mental health funding for the past 10 years. You know, we saw actually a 10% cut in the 2011 year. And that hasn't been restored yet. So I wonder if you can talk a little bit about that. You know, we know that a lot of these county programs are stretched thin. They got a lot going on already. And so what do you say to someone who thinks, hey, this is just another unfunded mandate?
Well, when you look at the term unfunded mandate, I challenge people when they say that. Is it? I mean, think about it. In Pennsylvania, that same individual, Derek, if he had chosen to go to the clinic, if he had chosen to stay in the clinic, if he had chosen to access services through the community provider, they would have had to have paid for him anyway. There's no additional cost here. You're taking an individual who, rather than going through treatment, staying stable, and living within the community, is now one of the greatest resource drains in the community, because you're going to treat them at very high expense, discharge them, treat them again, discharge them, treat them again. Again, AOT is for that class of individual where involuntary treatment doesn't work. It's not something we're imposing on any person with mental illness. The first argument is it's unfunded. Is it really? I mean, the courts are funded. The judge has got a salary. The DA has got a salary. The lawyers have got a salary. We're all getting paid. The clinics are getting funded. They're not seeing anybody they wouldn't ordinarily see anyway. The difference is that AOT is a tool. The courts are able to help. And what I resist most of all in the unfunded mandate is this thought that it's an order against Derek. It's an order for Derek. It's an order with Derek. It's an order to get Derek to wellness instead of illness. And AOT, I think, succeeds in that class of people. So unfunded, depends on how you look at it. My guess is they're entitled to those services anyway. And without them, in every circumstance that we have studied, the amounts of monies that we spend on these individuals in the revolving door eat up every bit of the resources we could be devoting for individuals who want to go to voluntary services.
Well, thanks for explaining that, Judge Kazin. And I'd like to maybe follow up on just one other note on this, which is that sometimes what I hear from counties is that because it's not something that you can't compel a person to participate in the way that a judge might be acclimated to doing, that it has, so to speak, no teeth, that it sort of requires a person to go along with it. And that's something that I know other states have had success with this model, so I know there must be a way in which it can work. But, I wonder if I fully understand that.
Well, I think you begin with the premise and as follows: just because a person is seriously mentally ill, just because the illness is preventing them from living a healthy life, doesn't mean they're ignorant, doesn't mean they're stupid, and doesn't mean they're foolish. And it has been my experience that in the vast majority of the individuals who are ordered to outpatient treatment before a court, it's this thing called the black robe effect. Just because I have schizophrenia doesn't mean I don't think I know what a judge is. And I am no different than my neighbor who would stand before the judge. And yes, there are individuals who will not comply with AOT. There are individuals where the court order is as good as a piece of paper in the trash, as there are individuals on probation who fail, as there are individuals in parole who fail, as there are individuals on divorces who fail, as there are. The failure is not the reason to not look towards the AOT, because you want to look at the overwhelming success. Mind you, and for Pennsylvania, I would tell them that if they look across the nation, they will see that the vast majority of AOTs, and it's math. I mean, it's best practices. It's been studied by everyone from the state to the feds. There is anywhere from a 70 to 80% reduction in hospital rates and commitments. There is an 80 to 70% reduction in costs to those individuals across the nation. Even if it were just 50%, what would you give for Derek for him to live 1 year without going to the hospital? What would that do to our jail not having had arrested him 5 times? What would that do to Derek if he had been the next headline?
And I'd just like to follow up with you one more time, Judge Casey, because I know there's some concern that the law lacks clarity. So, maybe counties and district attorneys and agencies don't know exactly how to operationalize it. Can you speak to your experience with that as well?
Sure. Initially in any law that's written, there is always unclarity. In particular, when you do a new, what's called statutory scheme. You work through it. You pick, as we did in Bexar County, we are a 10 or 12 year success in the making. I mean, it's not, we didn't do it in one day. It took a while. So you apply the statute that you have in Pennsylvania. And in particular, Pennsylvania has a great statute that allows you to take somebody who's already in an inpatient commitment, and before you discharge them, change that to an outpatient order. So you get them stable just to the point that they're stable, and then the courts take over on the outside. Why put Derek in prison? Why put Derek in the hospital any longer than he has to be? But also recognize that Derek needs to be changed, has to be helped with a further court order. The Pennsylvania statute is pretty clear on that. There are going to be some bugs in every statute, in every state, including Texas. But you take one person, you save that person. And if it doesn't work, you fix it so you can save the next person. That argument that there's not clarity or that it's cumbersome isn't any different, I think, than either the district attorney, myself, the public defenders, the prosecutors, anyone else doesn't go through every day. And it'll work out, just as it did in Bexar County. I really don't find Pennsylvania's law that cumbersome, and it seems pretty straightforward to me. It's just a question of wanting to do it. And that's why I would end with where I started. Is Derek an acceptable loss? He's not.
Thanks for that, Judge. Eric, you've been in an AOT program. What would you tell the DA about the impact that experience had on your life?
Thank you for your question. Thank you for the opportunity to speak with you. Prior to being in AOT, I had a history of red flags, the type of warning signs that parents and caregivers are told to look for by counselors and educators. My grades took a turn for the worse when I was in middle school, and by the time I reached high school, I was barely passing from one year to the next. I became addicted to drugs, both prescribed and illicit. Then I dropped out of high school in my junior year, got a GED, and failed out of college in my second semester. All of this was directly related to my serious mental illness diagnosis, which at that time was bipolar disorder, but I had no ability to understand that prior to AOT. Before AOT, I didn't understand my illness, how to manage it, and I often didn't even believe I was ill at all. My relationships with my family and my friends disintegrated. Delusions, hallucinations, and paranoia eventually became a major part of my life. So much so that I was convinced I was working with the FBI and the CIA, similarly to what's been talked about earlier in this discussion. I was positive I had broken codes that gave me information to prevent assassination attempts on world leaders. I once sat awake for 3 nights in a row in a hotel surfing the internet for clues about these kind of threats. And then I showed up at my local FBI headquarters, where I delivered a psychotic rant to several visibly concerned FBI agents. Soon thereafter, I was arrested for the nonviolent offense of trespassing, an event that was a product of my unstable and deteriorated psychiatric state. After being jailed for about a month without treatment and care of any kind for mental illness, I was transferred to the San Antonio State Hospital, which is where I was diagnosed with schizoaffective disorder. From that point on, I had decompensated 2 more times over a few short years, each of those times followed by an AOT order. My third and final AOT order ended about 8 years ago. And since that time, I have renewed relationships with my family and myself. With thanks to my AOT treatment team, I got back on track for a healthy life. They recognized I was being held hostage by my own mind and freed me from all of that through their combined efforts of psychiatry, social work, and a civil court order. The judge overseeing my AOT order, Judge Kazin, who's part of this discussion, provided my assigned social worker time to drive me to my local community college. My social worker, that school's disability advisor, and I had a productive meeting about me getting disability accommodations so that my college experience was set up as best as possible for me to achieve my goals. My AOT team was fully invested in making sure that I could manage my diagnoses to then pursue a future of realistic goals and dreams. This was part of the discussion at each of my AOT hearings, which were meetings about my care and goals, attended by me and my AOT treatment team. Their support set me on a path that could not have existed without them. I've graduated magna cum laude with a BA in psychology and am now a graduate student pursuing a master's degree in social work so that I can help others as I've been helped. Without question, the collaboration between everyone on my AOT treatment team was the catalyst for me moving toward reality and away from insanity. And everyone on the team had a part in that. SMI presents a multifaceted gamut of very complex issues, and an AOT treatment team is a formula for success because collaboration rarely makes things worse and often makes things better. My team involved me in decisions about my care, resolved problematic and dangerous symptoms, and then released me from AOT when I was ready. Put simply, AOT saved my life by giving me the care and treatment I needed. My AOT treatment team, which consisted of a judge, psychiatrist, social worker, and others, went from being champions who helped manage my care to teaching me to be my own champion so that I didn't need them anymore. I now see a psychiatrist, get monthly lab work done, and stay mindful about engaging in healthy choices, all without the need for court-ordered AOT. My AOT treatment team worked hard so that I wouldn't need them anymore, and my family wouldn't need them anymore. There are so many families and caregivers out there struggling to get their loved ones treatment before some form of tragedy strikes, and AOT is absolutely one of the best ways to provide treatment before tragedy. I survived SMI and turned my life around, and if we want others with SMI to be able to do the same, to become healthier, better functioning members of society who can pursue goals and dreams instead of being relentlessly tortured by untreated, undertreated SMI, then we have to give cities and communities, large and small, the knowledge and tools to create and implement strong AOT laws and programs. If you take one thing away from what I say here, let it be that AOT saved my life and allowed me to find health and happiness. And with your support, it can do so for others.
Yeah, thank you so much for sharing your story, Eric. It's really compelling, and I really appreciate you being here and being willing to talk firsthand about your experiences. Elizabeth, let's turn to you. You're the head of research at the Treatment Advocacy Center, and you've just received a call from the district attorney asking for data about the effectiveness of AOT. What's your input on this level? What's coming to mind whenever you talk with him?
Well, it's hard to provide a better argument for the role of AOT in improving lives after Eric's sharing his incredible story. But there is a robust evidence base on the effectiveness of assisted outpatient treatment. As it's been said, for some people, the overriding reason for non-treatment is an inability to recognize or acknowledge one's illness and therefore their need for treatment. This really contributes to people getting caught up in the revolving door, cycling through emergency departments, the criminal justice system, experiencing homelessness. And this is really the population for whom that assisted outpatient treatment is designed, just like this experience with Derek. The first AOT research was published in the early 1980s. However, they're still publishing new findings today. Some examples: in a study conducted in New York, researchers found that assisted outpatient treatment participants had a reduction of 83% in their arrest rate compared to the being prior they were enrolled in assisted outpatient treatment. In Florida, AOT reduced the average number of days spent in jail by 75%. In addition, it has been reported there's a 74% decline in homelessness for New York assisted outpatient treatment recipients compared to the 3 years prior to being enrolled in AOT. Research conducted in Ohio, a Summit County, Ohio program found that after 12 months of participating in an assisted outpatient treatment program, individuals experienced significant reductions in hospital admissions and the days spent hospitalized. And of course, this decline in hospitalizations and really contributes to the findings that in Ohio, AOT program resulted in a 40% reduction in cost associated with the program, because hospitalization days is one of the largest drivers of cost for this population. Similarly, in Nevada County, California, they found that for every $1 spent on their AOT program, they saved an additional $1.81 in reduced hospitalizations and incarceration costs. And I think to finish, the most compelling research finding out of all of this is an analysis of the 2016 federal grant AOT programs, which they found that 92% of participants in an AOT program agree or strongly agree with the following statement: "I liked the services that I received here."
Thanks for sharing, Elizabeth. And now I'd like to turn it back over to District Attorney Weintraub to kind of, as we go towards wrapping up our discussion today and our scenario. And of course, this was a fictional scenario with a fictional person named Derek in it. District Attorney Weintraub, you know and I know that this is a fictional scenario based very much on real cases and real people who some of whom you have met or I have met. So it's very important to both of us, I know. I'd like to ask, is there additional information based on what we discussed in this scenario that you would need to respond to the concerns of people in your community, or just more broadly, you know, what have we kind of not touched on yet that you really want to focus on right now?
I think that what we've discussed today has been incredibly compelling to me. Judge Kazin very eloquently put it, but certainly no better than Eric Smith, who is living proof that AOT works. I think the issue becomes trying to transform government, which is used to the status quo and saying we can't, into an engine for change to say we can and let's solve the problem. So that's the next issue. It's a challenge. I accept the challenge, certainly here in Bucks County. And as many of you know, we are meeting to try to make some progress here. But I think that the resources are available. It's just a reallocation of resources. This has been very helpful, and I'm hopeful. I still remain hopeful that AOT can be a part of how we do things in Bucks County. And somebody has to be first in the state. The law is there. Let it. Why not Bucks? Let it be us. Bucks is best.
As to what the DA just spoke to, I have to tell you, someone does have to be first. You know, in Texas, we didn't have AOT, and for all the success Bexar County has had, we were the first ones to do it, and we had to figure out how to get there. And now, finally, other jurisdictions are beginning to follow suit, and now we have AOT starting to spread across the entire state. And I would, as a practical point, ask this. Most of us in this profession have heard of drug courts. There's now a whole army of people who are sober, a whole Bible of statistics about how effective drug courts work. I was one of those guys that was around trying to start a drug court when there wasn't one. Everything has to start. You have a functional, rational statute in Pennsylvania. You have a scheme that works, and you have people who should not be destined to be on the revolving door. And it's just that simple.
So I can quite obviously speak to the AOT program I went through because it was my personal experience, and I lucked out in having you as being the one who presided over it because you valued collaboration between all of the disciplines and types of experts that should be involved when there are complex cases of SMI like I had. There was you, there was the social worker, there was the nurse who was involved in making sure I could get my meds. There was the attorney who was part of the hearings, making sure my rights weren't violated. All of these different people involved. And I know that AOT can look different from one area to the next, geographically speaking, and some areas don't necessarily implement that wide continuum of different types of experts being involved. And I've never personally asked you this question, so I'm curious, what did you see that had you specifically value knowledge that if I bring in all of these experts to be part of a team, I'll see better outcomes likely with the people I'm serving, the people who are on the AOT order?
Well, that's an excellent question because it actually explains a bit of why Pennsylvania may be resistant to implementing AOT, why not a single AOT is out there. The first issue is always going to be that people don't want judges and DAs and lawyers involved in their lives. And that especially goes to the medical community. That especially goes to providers. And once they look at the way an AOT is set up, and there are, you're right, everybody can do AOT differently, but as in the drug courts, as in any other therapeutic court, there's a model that develops. And in that model, once the participants and the stakeholders realize it really is a team effort. I am not a physician. I am not a psychologist. I am not a caseworker. I know nothing of that. They are the professionals. But I can bring to the table a mechanism where maybe somebody might listen long enough that the doctor can have an effect, that the caseworker can maybe have him show up on time to take him somewhere for an injection or for medication, or maybe develop a conversation to understand why it is that you're continually going to jail or not going to jail. We are a team, and it works as a team. And in Pennsylvania, my thought is that probably the reason there's a resistance is because people don't understand that concept of AOT. It is not a court banging a gavel, sending somebody to prison. It is not a judge ordering the caseworker to be there at 3 o'clock or else. It is a mechanism to make sure that Derek isn't a loss, that Derek, for example, in our scenario, should be treated with dignity and accord, and everybody should be held accountable to him.